Hello everybody, with EUS once more. We have a male patient, 52 years old, presented with recent onset of deep jaundice with abdominal pain, and lab showed high bilirubin level with...
Let's try to insert a balloon outside the patient first.
Mainly conjugated.
Yes, go on.
Can you give me the balloon?
Balloon, yeah.
Mainly conjugated with high CA19-9. On ultrasound, there is...
No, it's diazepid. No, yeah.
Oh, this is a side viewing?
do you hear me or...
It's okay, like still.
Yes, we
Yes, yes, and on ultrasound, there is... There is a large...
It's coming from the other room.
A large cystic mass with solid areas inside by ultrasound, with intrahepatic biliary radical dilatation and dilated common bile duct, and also by CT the same finding. And now for EUS with Professor Dietrich and Professor Paulo. Thank you.
Okay, good afternoon again. What we start by examination the pancreas, it's, let's say, worthwhile to start at 44 centimeters from the mouth, from the teeth. So we have three ideas of endoscopic ultrasound. 33 means subcarinal region. 44 means the tail of the pancreas, and if you can see here nicely, the left adrenal gland. Here is the spleen and parts of the kidney. So this is a beautiful sign of the seagull-shaped supraadrenal gland. This is 44. And 55 is the bulb of the duodenum to see the papilla from above. So endoscopic ultrasound might be pretty easy, 33, 44, 55. And what we are looking is there's a huge mass within the abdomen, really 15 centimeters by 15 centimeters in diameter. So this looks from a primarily glance. Paolo, what would be your suspicion for that?
He's a man, he's quite old but not so old. We cannot see now any pancreatic duct, so my primary idea is that it could be a cystic mucinous adenocarcinoma, but in the case of a dilated pancreatic duct, or in the case of the capability to look for communication of the pancreatic duct with this lesion, we can also expect to have IPMN lesion degenerated.
Yeah. So the idea is we have a multiloculated lesion, mass lesion, all over the abdomen next to the pancreas, starting from the tail, heading for the head of the pancreas, infiltrating the common hepatic bile duct. So the differential diagnosis is if you would have had a history of pancreatitis, pseudocyst formation. So first we have the differential diagnosis to differentiate between pseudocyst and neoplasia, and secondarily, if that is a neoplasia, because he has no history of acute pancreatitis, we are interested if this is a benign one or a malignant one. Brugge explained us in that beautiful publication, Gastroenterology, that the cut-off of pseudocyst and neoplasia is the CEA level of about 192 nanograms per ml. And from others, we know that the cut-off between benign and malignant disease is in between 400 and 800 nanogram per ml. So this is the first step we are going to do. And the second step is our cytologist and pathologist. The yield in that regard is about is about 60 to 70%. So coming to one procedure solution that would be CEA, but we perform for sure cytology, and our pathologist will give us that information if they can find cells, what kind of cells, and if those cells are benign or malignant.
Christoph, may I ask you, in this case, are you going to take the fluid and your expectation is to have cells in the fluid, or are you trying to go for vegetation or for solid masses? What is your idea or your plan?
So if I have solid components within the cyst, I would try to come close to that solid components to get cells. But this might be true for some of those regions right on here. So I wouldn't only go for fluid, but I would also go for cells.
So what kind of needle are you using in this case?
In this case, you have been suggesting it might be mucinous cyst adenocarcinoma. That means mucinous cells, so we're going for the largest diameter which we can afford. This is 19 Gay.
So you got it.
Yeah, so
This is here. Is here.
Oh, yeah, very good.
We will move for just 1 minute to the balloon dilatation, and we'll go back to you, Professor Dietrich.
Very nice.
Thank you. Okay, thanks.
Go. Okay. Do you want us to pull the stylet away, or do you use with the stylet?
Like that. But let's say what happened. Could you hold it for a second?
Okay.
There we are. So now we have to see if it's. Can you see it over here? Here we are.
Yes, on the right side of the picture.
Yeah.
This is probably part of the pancreatic parenchyma there. Okay. Can you see the stylet here?
Yeah.
And then can you see?
So we are inside of that lesion, pretty easy. So we are on the screen?
Yeah, you are.
Okay, so we inserted at a site of that pseudocyst or cystic neoplasia where we suspect that solid material can be achieved. So Paolo shows by the arrow that the needle seems to be at a pretty good place. So now we start to remove the stylet, and we will go for suction. Yeah. Okay.
This is a 19 gauge.
This is a 19 gauge needle, and we perform this with a 19 gauge needle because we suspect mucinous fluid. You can open it, and mucinous fluid means high viscosity, and therefore we have to use the highest diameter which can be achieved. So.
Are you using antibiotics intravenously this patient?
We have been preparing that patient right before the examination. I was asking about antibiotics, and ceftriaxone, for example, 2 grams would be a good choice, and we performed it before every kind of puncture of cystic lesions. So right now you can see here nicely that fluid is coming out, and this fluid, have a look on that, could be also pseudocyst fluid. Let's say the normal neoplastic fluid is perhaps much clearer. So some sort of inflammatory process has to be considered.
Professor Dietrich, you said that the malignant one will be darker or clearer?
If you have, let's say, mucinous aspect, the fluid is normally much clearer. So looking for that, there's for sure an inflammatory and infective. Yeah, it could be secondary or secondary infected. And later on, after the final diagnosis of CEA and cytology, we have
Sorry,
to
Professor
think. Yeah.
Go to balloon dilatation for 2 minutes. I'll be back for you. Okay?
Okay, so we can remove that, so we have some fluid. And bring the what we had to answer, because one of our differential diagnoses has been also intraductal papillary mucinous neoplasia, to identify the pancreatic duct. And you can see nicely at the arrow that the pancreatic duct is delineated right on here, and that we can measure this duct, and we talk about 1.1 millimeter. This is really exciting, and looking for the end of that duct, you can see a stop, a disruption of that pancreatic duct nicely here. So coming to a differential diagnosis, one of our differential diagnoses is no more within the scope. So IPMN, this is not for sure IPMN. So we have 2.5 differential diagnoses to think about. It's the pseudocyst, but patient's medical history is not really the typical one for that, because he has no episode of acute pancreatitis. And secondarily, a huge mass of mucinous cis-adenocarcinoma, presumably. And let's say we try to catch that diagnosis. Since this would involve most of the retroperitoneal space, it seems to be, if that diagnostic is in favor, inoperable. But first we need the final diagnosis, and then the concept if that patient would be operable or not. And even in the pseudocyst he has symptoms and therefore an indication for cyst drainage via the stomach wall. This is true also for the inflammatory origin of that disease, as well as for the palliative treatment in that